Hello, everyone. For the May Digest discussion, the topic was gastric dysmotility issues. And so I selected one of the most common inpatient conditions that we'll see, and that is diabetic gastroparesis. I wanted to then focus on a medication, relamorelin, and an endoscopic procedure, GPOM, for the treatment of such. So diabetic gastroparesis is defined as a delayed in gastric emptying in the absence of any mechanical obstruction. Cardinal symptoms of gastroparesis include abdominal pain, postprandial fullness, bloating, early satiety, nausea, and vomiting. The pathogenesis of diabetic gastroparesis is theorized to involve dysfunction of the vagal nerve, hyperglycemia, disruption of interstitial cells of Cajal, and oxidative stress. Acute on chronic symptoms of gastroparesis often result in recurrent hospitalizations for patients seeking pain and nausea relief. Inpatient management strategies include use of IV or oral Reglan, erythromycin, azithromycin, and then encouraging smaller volume, more frequent meals of low residue items. Barriers to the prolonged use of this therapy include undesirable effects and risk of tardive dyskinesia with Reglan and tachyphylaxis of erythromycin. Domperidone is an efficacious option to be considered in the outpatient setting for management of gastroparesis, but remains not approved by the FDA for sales in the U.S. Relamorelin is a synthetic ghrelin receptor agonist with potent prokinetic effects that have demonstrated desirable efficacy to reduce symptoms of abdominal pain, fullness, bloating, and nausea attributed to diabetic gastroparesis. In phase 2A and 2B studies for diabetic gastroparesis, relamorelin demonstrated superiority to placebo to improve these symptoms and was found to accelerate gastric emptying, but was not evident to reduce vomiting frequency when compared to placebo. Phase 3 studies remain ongoing, and as of now, relamorelin is not yet FDA approved. Endoscopic pyloromyotomy, or GPOM. GPOM is an acronym for gastric peroral endoscopic myotomy, an endoscopic approach to pyloric sphincter myotomy. Incising the muscular ring of the pyloric sphincter enhances gastric emptying to alleviate symptoms of gastroparesis. Data encompassing GPOM subjects reported approximately 70 to 80% of patients perceived significant improvement of resolution of gastroparesis symptoms. In contrast, the reported efficacy of endoscopic pyloric Botox injections to treat gastroparesis was only 40%, and with a limited duration of up to only 3 months. And here's kind of some imaging that shows this pyloric muscle sphincterotomy. I'm curious to hear from the physicians that actually have possibly firsthand experience with either of these two, the medication, if they have more knowledge basis on relamorelin and its effects versus the actual use of the GPOM procedure and kind of real world effects for these type patients, to see if this is something to implement in our inpatient care. Here's a list of references.